Hi, I'm Dr. Swetha, your internal medicine educator at Medicoz Community. I hope I'm audible and visible to all of you. Please let me know by a thumbs up in the chat box. Then we'll proceed ahead. Okay. So if I'm audible and visible, I'd like to introduce you people to Medicoz Community, which is an online platform to help students make their life simple and easy while preparing for their next exam. And we'll also be offering a lot of plans which include interactive live lectures by expert faculties who will also be giving you test series and a lot of question banks with conceptual clinical based questions. We have started also an early bird offer which includes 3,000 slots where the first 3,000 will get premium discounts on all our plans. So I want you to make complete use of it. And today's lecture, I want you to participate, take a pen and paper, write down the important notes, and put in the doubts in the chat box. Okay. So before we move ahead to our question proper, I would also like you to have a look at our February schedule. So the February schedule includes OBGY and general medicine as of today, then followed by further sessions on 12th, 16th and 18th. This schedule will be updated time and again. Okay. So this session is specifically devoted and dedicated to internal medicine clinical questions. So 25 questions have been divided into two parts. So part one I will be taking today, which involves 12 questions. All right. So moving to the first question without further delay. A 45-year-old patient was brought to the emergency with complaints of breathlessness. On examination, the JVP is raised and fails to fall during inspiration. What is not likely the cause of his breathlessness? Always importantly, read the question very carefully and slowly because here they're talking about JVP and breathlessness. This is the first clue that gives you that this is a cardiovascular system involvement. They also say something about the JVP failing to fall. So this is a sign that you have to pick up. Okay. And the last part is they're asking which is not likely the cause. Okay. So option A is right ventricular infarction. Option B is constrictive pericarditis. Option C is cardiac tamponade. And option D is restrictive cardiomyopathy. So I want students to first try and answer this themselves before I give you the answer. Okay. So first, what is this sign? Let's go and read about this sign. This sign is called the Kussmaul's sign. Okay. It is defined by either a rise or a lack of fall of the JVP, the jugular venous pressure, with inspiration, and it is classically associated with what? Constrictive pericarditis. But it is also seen in other conditions. What are the other conditions? Restrictive cardiomyopathy, your right ventricular MI, your pulmonary embolism, and severe pulmonary hypertension. What you have to remember is SVC obstruction is also a cause of Kussmaul's sign. This has been asked in your previous AIMS paper. Okay, so they're going to make conceptual questions a little more difficult. It's not going to be all easy and cakewalk. So you remember the important points at least. Okay, so JVP, let's revise quickly. What are the waves in the JVP? A wave, that is your atrial contraction. C wave, that is the tricuspid valve closure. And V wave, that is the venous filling of the right atrium. So among these, what have we got previously as MCQs? The very favorite, absent A waves. Okay. Where do you see absent A waves? You see it in AFib. Okay. Then where do you see canon A waves? Canon A waves. Can someone write it in the chat box for me? Where do you see canon A waves? We see it in complete heart block. Okay. And what else? Where do you see CV wave? where do you see CV wave or large V waves known in tricuspid regurgitation. Okay, so the answer to the previous question, as you can see, this list does not include cardiac tamponade. So cardiac tamponade is not likely the cause of his breathlessness. So this is a very important concept for your NEET PG upcoming also. Please use this as your revision if you're giving the upcoming NEET PG 2023. For your next also, this is a very important concept. Next question is 60-year-old chronic smoker. So the key word is chronic, correct? He presents with breathlessness and palpitation. Comment regarding the X-ray and ECG finding. So this question is testing both your radiographic skills as well as your knowledge in general medicine. So you need to know what is this chest X-ray representing. What does this show? Okay. And you should also be able to interpret this ECG. At a glance, what can you see in this ECG? You can see that the heart rate is high, correct? So this is probably a tachyarrhythmia, correct? So now we need to interpret this X-ray and this ECG. So let's go and see what options we have. Option A is bronchiectasis in the chest X-ray and atrial fibrillation in the ECG. Option B is emphysema in the chest X-ray and MAT, that is multifocal atrial tachycardia in the ECG. Option C is emphysema again in the chest X-ray and atrial flutter in the ECG. Pneumonia in the chest X-ray and SVT in the ECG. Very, very important. Try to answer this before I give you the answer myself. Okay? Okay. So the answer is going to be emphysema on the chest X-ray. Why emphysema? Because there is hyperinflation of lungs, flattening of hemidiaphragms, increased spaces between the ribs, saber sheath trachea, and paucity of vascular markings and tubular heart. So let's review whether we have all this. Yes. So can you see that the lung fields are hyperlucent? You can see there's a flattening of the hemidiaphragms. You can see widening of the intercostal spaces. So the ribs are very far apart. Can you also see that the heart is just behind the sternum? So a tubular heart. What is saber sheath trachea? Saber sheath trachea is the intrathoracic trachea which gets narrowed. Alright. So the answer for chest X-ray is emphysema. We are clear regarding that. Correct? Next. How do we approach tachyarrhythmias? Okay, the approach to tachyarrhythmia is, first step is you identify whether it is a narrow complex or a wide complex tachyarrhythmia. Okay, so a narrow complex tachyarrhythmia meaning the QRS complex is less than 120 milliseconds. Correct? Okay. So if it's more than 120, that means it is arising from the ventricles. In this ECG, what do you see? You see that it is a narrow complex tachyarrhythmia. So once you know it is a narrow complex tachyarrhythmia, next you will see whether this is regular or irregular. Okay. So you can see from this first lead itself that it is irregular. Okay. The RR is varying. Correct. So it is an irregular narrow complex tachyarrhythmia. What is the next step? You will look for P waves. Can you see P waves here? Yes, you can see P waves. But how do the P waves look? Can you see? They are of different morphology. They do not follow a single pattern. Especially the rhythm strip, you can make it out. This P is different, this P is different, this P is different. In fact, this P is inverted. Correct? So that means I have more than 3 different types of P waves. This means the patient is suffering from multifocal atrial tachycardia. So first, let's review. We understood it is a tachyarrhythmia. Then we narrowed it to a narrow QRS tachyarrhythmia. And then we decided that it is irregular because the RR was varying. Then, if the P wave is present or not, if it is absent, that means it is atrial fibrillation. It is present but of different morphology, then it is MAT. So the answer here will be emphysema and multifocal atrial tachycardia. This is the answer for question number 2. I hope it's clear. I hope everyone is following me. If you're not able to write down everything, at least write down the important points. Okay. So moving on to the third question. Okay. So a 24-year-old patient presenting with acute ST elevation MI. So this itself is, an alarm sign for you. Why? Because it's a 24-year-old patient, very young patient, and MI is there. So on detailed evaluation, he was diagnosed of a disease known as pseudoxanthoma elasticum. Which of the following is not a feature of this syndrome? So can you see here the level of difficulty which is happening in your INISS and your NEET INIPG, CT and your NEET PG is very high. Your pseudoxanthoma elasticum is actually a syndrome in dermatology. Okay. So this has been multiple times asked under dermatology in your INICT. But this same dermatological syndrome also has a cardiovascular component. That is why the patient is having ST elevation MI. So you need to know this syndrome in detail. So which of the following is not a feature? Is it premature atherosclerosis? Is it angioid streaks on fundoscopy? Is it Palmar-Creese xanthomas? Or is it cobblestone appearance of the skin? Which of the following is not? Okay. Which of the following is not? Try to answer this question before I go ahead. Okay. So pseudoxanthoma elasticum. Please remember this mnemonic. It's a very funny mnemonic called chicks. Okay. So the C stands for chicken skin or plucked chicken appearance, also termed as cobblestone. Okay. Then you have upper GI hemorrhages. And then you have angioid streak and blue sclera, coronary artery disease, which our patient has, okay, leading to MI, claudication because of peripheral vascular diseases, and squeaky valves, okay. So all of this is there in our options, except what? Except Palmar-Creese xanthomas. So can someone tell me what is Palmar-Creese xanthomas? Pathognomic of? They are pathognomic of hyperlipoproteinemias, specifically type 3. Hyperlipoproteinemia type 3 cause Palmar-Creese xanthomas. So take home message, pseudoxanthoma elasticum is a dermatology question. This syndrome can present with MI. Hence, it can also be asked as an internal medicine question in your NEET PG and INICT. One more important cardiovascular syndrome that you cannot miss, you cannot skip is Marfan syndrome. Okay, the very famous Marfan syndrome. Again, it can be framed similarly. The mnemonic is Marfan's itself. M stands for mitral valve prolapse. A is arachnodactyly. R is retinal detachment. F stands for fibrillin defect. That is FBN1 gene on chromosome 15. A is aortic aneurysm. N is negative nitroprusside test. So this was asked in your INICT previously. Okay, negative nitroprusside test, positive in homocystinuria. Okay, and subluxated lens. So please remember these two important mnemonics. One is your chicks and the other is Marfan syndrome. Okay, with this we move on to our fourth question. Alright, if you want me to slow down or if you want me to re-explain something, please put it in the chat box. We'll be happy to do that. So, fourth question is a 55-year-old hypertensive presented with complaints of right-sided hemiplegia with aphasia past 3 hours. On examination of febrile, a BP of 170 by 100, which is high, RBS of 172, GCS of 10 by 15, So what is the next best step? Okay. So what is the next best step? See, this is a seemingly very easy question, but a lot of people make mistakes in this. Okay. Because you need to know the steps of approaching a stroke patient. Okay. So it's not rocket science. Everybody would have known that right-sided hemiplegia with aphasia means there is a stroke. That is a cerebrovascular accident. Correct? So option A, do you do a presumptive diagnosis of acute ischemic stroke and go ahead with IV thrombolysis? Or do you reduce the BP with IV antihypertensives? Or C, you treat the hyperglycemia first? Or D, you rule out intracranial hemorrhage by doing a non-contrast CT. So which of these do you think should be the answer or should be the next best step if you are the emergency doctor that night? Okay. So should we reduce BP? That is the question. Should you reduce the BP? At what BP do you think the patient is in danger and it should be immediately reduced? The answer is 185 by 110. So if the patient presents with 185 by 110 and he is a candidate for thrombolysis, it should be reduced with antihypertensives. And what about hyperglycemia? When do you treat it? When your RBS is more than 180 or hypoglycemia when it is less than 60. Always treat BP and sugar before you go ahead with IV thrombolysis. Okay. But in this question, both the parameters are within the normal range. That is, they don't require treatment emergency. Okay. So, would you go ahead and do an IV thrombolysis or would you do an NCCT? The answer is you do an NCCT to rule out intracranial hemorrhage. Because if there is intracranial hemorrhage, then it is an contraindication for IV thrombolysis. In fact, you would be worsening or putting the patient in grave danger if you give thrombolysis in the presence of hemorrhage. So the answer is option D, do a non-contrast CT to rule out intracranial hemorrhage. All right. So I want you to be familiar with this. As soon as a patient comes to the emergency room and you are the doctor there, I want you to check this first. His plasma glucose, hydration, oxygen, temperature. So even if the patient is febrile, you need to treat his fever before you give IV thrombolysis, all right? And then you do a non-contrast CT, which is the answer for the previous question. If the non-contrast CT shows no hemorrhage, then you call it as an ischemic stroke. If it is less than 4.5 hours presentation, then we do a thrombolysis. Okay. If it's more than 4.5, then we consider a thrombectomy. That is a mechanical thrombectomy. All right. So acute stroke management is again very, very important for your upcoming exams. So never forget. First, we dealt with JVP. Okay. Then we also dealt with some syndromes. Okay. Now we are dealing with stroke. Okay. So these are extremely important for you to remember. All right. Okay. So question 5, a patient presents to emergency with vertigo. Okay. Numbness of ipsilateral face and contralateral limbs. So let me draw a diagram for you so you don't get lost when a lengthy question comes. So he says ipsilateral face and contralateral limbs. Correct? So these two, he says they are numb. Correct? There is hoarseness, dysphagia, and ipsilateral Horner's syndrome. What is Horner's syndrome? Can anybody tell me? What is Horner's syndrome? Horner's syndrome is a disease of what? Your sympathetic chain. It is characterized by ptosis, anhidrosis, meiosis. Okay. And loss of ciliospinal reflex. All right. So this is an affliction of your sympathetic chain. So what all can you infer from this? You can infer that There is something crossing. So there is a crossed hemisensory loss. Correct? So whenever there is a crossed hemisensory loss or a crossed hemiplegia, immediately what should come to your mind is that is your brainstem is affected. Okay? Brainstem is the only place where you get a crossed, that is one side face and the other side limbs getting affected can be seen in the brainstem. So now that we have localized, okay, there is some problem in the brainstem. What else clues does this question give you? It tells you that the 9th and 10th cranial nerve, that is your glossopharyngeal and your vagus nerves, they are affected. So your 9th and 10th, so your lower cranial nerves. And it also says your sympathetic chain is affected. So all of this merge where? This is where your concepts are tested. All of these, they merge in your medulla, the lateral part of your medulla. So this is a stroke in the lateral part of your medulla, which is also known as lateral medullary syndrome or Wallenberg syndrome. All right. So Wallenberg or lateral medullary syndrome. Once you know, then it will be very easy for you to find out which is the artery. The most common artery affected in Wallenberg is your pica, that is your posterior inferior cerebellar artery. All right. So this seems to be difficult, but once you start reading and going over through your concepts, you will understand that they have a set pattern. Brainstem syndromes, I know, can be very difficult for a lot of students out there, but once you start solving, you will understand that there is a pattern. So let me help you with these brainstem syndromes. How can you tell just with one look at your question whether it's the pons, whether it's the midbrain or the medulla? Okay. So these are some of the important syndromes. You don't need to remember all of them. Okay. So out of this, you should concentrate on the first three, that is your Weber, Benedictine, North-Nagel. Okay. What is the common point in all three? You can notice that is the cranial nerve 3 involvement. Can you see? Cranial nerve 3 involvement will be there in all three. Correct? And this will be ipsilateral and they will have contralateral hemiparesis. So these three syndromes arise from where? From the midbrain. All right. Okay. So next is foveally and 1.5. What is the common point? It is cranial nerve 6. Okay. So foveally and 1.5 arise from where? Because it's cranial nerve 6, it is pons. All right. And in lateral medullary and medial medullary, you have to just remember two. Most common being Wallenberg and the second being Digerine. Okay. So these two, you will see lower cranial nerves involvement. Like lower cranial nerves meaning what? Hoarseness of voice, dysphagia, sympathetic chain involvement, correct? So lower cranial nerve involvement will be seen in what? In medulla. So I want you to remember that if your question has cranial nerve 3 involvement, then it is midbrain. If it has 6, then it is pons. If it's the lower cranial nerves and it is also showing sympathetic chain involvement, then it is the medulla. So like this, you can compartmentalize these brainstem syndromes instead of just having a rote memory of it. All right. Instead of by hearting, you can just conceptually break this down. Okay. So once you know which place it is, I'm just taking this a step ahead so that you're very clear. From next time onwards, you're not going to be scared when you read these brainstem syndromes, okay? You just have to remember the posterior circulation. Very simple. Two vertebral arteries join to form the basilar artery. But before they join, what do? They give out a branch. This branch is your pica. That is your posterior inferior cerebellar artery. So now, as soon as the pica is given out, the basilar artery is formed, which gives out first branch, that is your anterior inferior cerebellar artery. Simple. The basilar artery goes up and again divides into superior cerebellar arteries. The last one is your posterior. I'll just write this for you here. So the last branch given by the basilar artery is your posterior cerebral artery. So don't get confused. Okay. This is the last ending of your basilar artery. So your basilar artery supplies the pons, your pica supplies the medulla, and your posterior cerebral artery and some part of basilar artery, okay, these two supply the midbrain. Very simple. Okay. So you can replay this again and again, get your concepts clear. Okay. So you don't have to by heart from now onwards all your brainstem syndromes. Okay. We go ahead next to our sixth question. Okay. A 72-year-old male is brought to the hospital with confusion and drowsiness. Pay attention that his son says that he has been urinating more frequently than normal and eaten very little over the past 7 days. That means he's getting dehydrated somehow. He's losing a lot of water. Okay. And he's not drinking enough. Then you also get he is an elderly confused. Elderly confused. Okay. A capillary blood glucose is 800 mg per deciliter. Very high. Which of the following would not be seen? Okay, don't miss this note. Would not be seen in this patient. Again, this seems very difficult, but it is the most easiest question that we have solved so far. Why so? Because with high blood glucose, there are only two emergencies that you should know. Only two high blood glucose emergencies is DKA and HHS. Simple. Okay. So you should know just one more reading. That is DK present with what sugars? HHS present with what sugars? DK is 250 to 600. HHS is 600 to 1000. So what are they talking about? They are talking about HHS, correct? So he's asking you what is not a feature of HHS. Does HHS have normal pH? Yes. Does HHS have pre-renal azotemia? Yes. What is pre-renal azotemia? Simple. Patient will have a AKI because he's lost lot of urine. So he's depleted. That is why he has a pre-renal azotemia. Serum osmolality is 370 milliosmoles. That is more than 350. All these are features of HHS. What is not a feature? It is your Kussmaul's breathing. Okay. Now students, don't get confused between Kussmaul's sign and Kussmaul breathing. Kussmaul's sign was seen in JVP, while Kussmaul breathing is seen in acidosis. Okay. Acidosis. So HHS will not have Kussmaul breathing. So this is your answer, option A. Alright. So please have a look at this slide where we can compare DK and HHS. This has to be, this is the basics of solving such MCQs. DK has hypoglycemia between what range? 250 to 600. HHS has severe hypoglycemia, so 600 to 1000. Okay, because of this severe hypoglycemia, you have elevated osmolality. DK has mild, metabolic acidosis, while HHS has pH more than 7.3. DK has ketonemia. What are the ketones that are formed? Can someone tell me? Can you tell me what are the ketones that we have? Acetone, acetoacetate, and beta hydroxybutyrate. Correct? So these are the three ketones that are formed in DK, while you don't have these ketone formations in HHS, minimal or negative ketonemia. But profound volume depletion is seen in HHS. That is why this leads to what? AKI or pre-renal azotemia. Important difference is elderly are prone for HHS while young in DK, and HHS has a longer protracted course of illness. So if I know this is a little difficult for you to remember all this, but at least you can remember the difference in the hypoglycemia and remember the difference in the pH. These two are a no-brainer, and everybody, every aspirant, every medico should know the difference. All right? Okay. Okay, students, let's go to the seventh question. I want you to be active for this. A 75-year-old male presents to OPD with high-grade fever, productive cough. All right. On examination, the respiratory rate is very high. It is 35. The heart rate is also high, which is 105. And BP is slightly on the lower side, 88 by 60. And how do you manage this patient? Okay. Option A is admit in ward, treat with levoflox and doxycycline. Option B is treat him on an outpatient basis with azithromycin and ceftriaxone. Admit in ward and treat with levoflox, or admit to ICU and treat with ceftriaxone and azithromycin. So what would you do if you were the doctor who is attending this patient in the OPD? Where would you admit this patient? That is the first part. And what would you give him? That is the second part. Okay. So how do you decide where to admit such patients? Is there any score? Can anyone recall any score, to admit pneumonia patients? Yes. The very simple score of curb 65. All right. So a very simple score of curb 65, where C stands for confusion, U stands for urea, R is respiratory rate, and B is blood pressure less than 90, or, important is or, the diastolic less than 60 and age more than 65. So our patient, shall we fit him into this criteria? His age is more than 65. So that is 1 point. Plus his respiratory rate is more than 30. That is 1 more point. And his BP is on the lower side. So total of 3 points. We don't have his urea levels. So this is his score. That is his curb 65 score. So now based on this score, we see that the mortality is very high. Correct? The mortality is very high, 3 or more. So we assess or we admit him in the ICU. All right. So this, you cannot send this patient home. All right. We have to admit him in the ICU. And what do we treat him with? This is the empirical treatment, which you should know. That empirical treatment of pneumonia, the first choice is a third generation cephalosporin plus a macrolide, that is azithromycin. Okay. So this is again a revision of your pharmacology, because they will ask you cephalosporin, azithromycin, where is it given in combination? Okay. So you should know the treatment as well as the criteria for admission in pneumonia. See, curb 65 is a very common, very basic and easy to answer questions. Do not make any silly mistakes in such type of questions. You can score full marks in these. Okay. Let's move on to the 8th question. All right. So moving on, we have a 82-year-old female with history of moderate aortic stenosis, presented with fatigue, weight loss, and night sweats. Okay. So the moment you see that there is fatigue, weight loss, and night sweats, some inflammatory process is what should click your head. Okay. And it had been for the last 14 days, correct? So the blood test results are updated below. Echocardiography revealed an intracardiac mass on mitral valve. Blood cultures revealed Streptococcus galeolyticus. What additional investigation should be performed? See, C-reactive protein is very high, 187. WBC count is also high. That means there is an infective pathology. Where is the infection? Can you see there is a mass on the mitral valve? So this is infective endocarditis. Okay. And they say that the blood cultures have revealed Streptococcus galeolyticus. All right. But the answer is, the question what they ask additionally is whether you have to perform a cystoscopy, a colonoscopy, bronchoscopy, or a hysteroscopy. What do you want to do for this patient? Would you like to do all the investigations, or would you like to pick one of these? That is the question. Okay. So let's approach this again by breaking it down. Can you tell me what is the criteria used for infective endocarditis? What is the name of the criteria? Can you put it in the chat box? Let me tell you that it is the modified Duke criteria. मॉडिफाइड ड्यू क्राइटेरिया। अब ये इन्फेक्टिव एंडोकार्डाइटिस है क्या, पहले वो तो बताते हैं। So infective endocarditis is an infection of the heart chambers or valves. All right. What do you see in infective endocarditis? You see that there are growth on heart valves. You see a lot of vegetations on these heart valves. So what if there are vegetations? So what if it's infected? They give rise to a lot of complications. How? They can emboli. These vegetations can cause emboli, and it can also lead to many inflammatory processes like glomerulonephritis. And these bacteria seed the bloodstream. So bloodstream infection. So to diagnose this serious condition, we have been given the Duke's criteria, where you have a major criteria which involves echocardiography and blood cultures, and the minor criteria where you have fever, your Osler's nodes, your Roth spots, your Janway lesions, okay, Janway lesions and Roth spots. I'm just writing down all this so that this is also your revision for the upcoming NEET PG. All right. So once you know this patient has infective endocarditis, next question, the blood culture is showing strep galliolyticus. Now, where is this strep galliolyticus? It was previously known as Streptococcus bovis. Okay. It has been renamed as Streptococcus galliolyticus. Now, where does this come from? Does it come from the skin? Does it come from the teeth? Where does it arise from? It arises from your intestines. All right. So it was found in a great association with carcinoma of the colon. Okay. So any polyp or colonic carcinoma, wherever there was a tumor, the bacteria, that is strep galliolyticus, which usually is a commensal, it gets attached or adheres to this carcinomatous region, and then it infiltrates the capillaries and enters the bloodstream, leading to subclinical infection. Then it reaches the heart and it damages the heart valves. Can you see here? The commensal streptococcus galliolyticus attaches or adheres to a tumor in your intestine, and it translocates into your blood and disseminates and colonizes your heart. All right. So you should understand, anybody who's having a streptococcus galliolyticus, elderly age group, might have a carcinoma colon. So that is why the answer for this is, to detect carcinoma colon, you would do a colonoscopy. All right. So you should remember this, because this also is your previous year INICET question. Okay, it has been previously asked in your INICET question. INICET question. So you should be thorough with such questions. All right. Okay. So ninth question is, a 42-year-old male patient came to emergency department with complaints of weakness of all four limbs, paresthesia, and difficulty in breathing. Deep tendon reflexes were absent. Relevant investigations were done and ECG obtained is suggestive of. All right, let's break this clinical scenario. Okay, you see there are four limbs weakness. That is your first clue, all four limbs. Next is difficulty in breathing, and your DTRs are depressed. Okay, and then there is an ECG which is showing lot of changes. So quickly, can we see what are these changes? Can you see here? This is your ST is depressed. Your ST is depressed. Your ST is depressed. Correct? So there is all leads showing ST depression. And you can also see here your T is inverted. T is inverted. And there is this huge wave. It is not the P wave. Why? Can you see here? The P wave comes later. The huge wave before the P. What is this wave? Can you identify what this wave is? This huge wave here. This is your U wave. Okay. The moment you hear U wave, the first answer that should come to your mind is hypokalemia. Okay. So among these answers, the options we have hypocalcemia, and hypercalcemia. So the answer is hypokalemia. All right. So I've just zoomed in or magnified the ECG for you. So this is the ST depression and the T wave inversion. What comes up is your U wave. All right. And then after that is your Chotuza T wave. All right. So you have to identify the different waves. Even in fact, you're not able to identify the different waves, you should remember that severe hypokalemia, severe hypokalemia can cause all four limb paralysis. All right, all four limbs, sudden onset paralysis. All right. So the question itself gives you a clue as to what could be the electrolyte abnormality. So this is very important for you to remember. So let's have a look at what are the different changes in hypokalemia versus what are the changes in hyperkalemia. Let's have a look. Yes. So the ECG features of hypokalemia. The earliest ECG manifestation, this again has been a question in your previous NEET PG exam. A decrease in T wave amplitude is the earliest manifestation. Increased P wave amplitude, prolongation of the PR interval, widespread ST depression. We saw this in our previous ECG, correct? Widespread ST depression, T wave flattening or inversion, prominent U waves, prominent U waves. This is best seen in V2 to V3, just like ECG we have discussed previously. So these are all features of hypokalemia. Quickly tell me what are the changes in hyperkalemia. So the first one is a no-brainer, peaked or tall T waves. Okay. So you can see the representation here. You can see tall peaked T waves, prolonged PR interval and loss of P wave. So today we've come across two conditions where you have loss of P wave. What was it? One was AFib, where you don't have a P wave, and the other is hyperkalemia, where you don't have a P waves. So these are the two conditions. Next is widening of the QRS complex. Can you see how wide this QRS complex is? And appearance of sine wave. This is a sine wave, okay, or a sinusoidal wave. So you should know hypokalemia and hyperkalemia. These are the basic two ECGs in electrolyte abnormalities that you shouldn't skip, okay. So note all of this down and keep revising. Okay. So moving on to the 10th question. Again, a favorite topic for most of the competitive exams is hepatitis B. So let's go to the question. An intern suffers a needle stick injury while treating an HbsAg positive patient. All right. HbsAg positive patient. Which marker will indicate recent HPV infection in this patient? The key word here is recent. Okay. What do you mean by recent HBV infection? It means the patient has been infected with HBV in the past 6 months. That is, what are the modes of HBV infection? It could be a needle stick injury, it could be blood transfusion, it could be sexually transmitted, it could be mother to child. So all of this must have occurred in the past 6 months. So which marker will help to tell you that he got a needle stick injury just 6 months ago? Not very far off. So is it HbsAg? Is it HBe antigen? Is it IgM anti-HbC antigen or IgM anti-HbS? Okay. Just note all of this carefully. We'll rule it out one by one. So is it HbsAg? What is HbsAg? It is the first marker that we do for everybody. Is it seen in acute infection? Yes. But is it also seen in chronic infection? Yes. It is also seen if the patient has not seroconverted. It can be seen in both acute as well as chronic. Next. Is HBe antigen a marker of recent infection? It is a marker of infectivity. Okay. It tells you how fast the virus is replicating. It doesn't tell you the timeline of the infection. All right. Is it IgM anti-HbC antigen? Yes, this is the answer, right? So I will tell you why this is the answer. So this is the famous graph of your hepatitis B markers. You can notice that as soon as the HbsAg is seen in the bloodstream, your IgM anti-HbC also appears, and it is lost by 6 months. All right. If it is present, that means he has just got it in this past 6 months. After that, what happens? After 6 months, you have something known as total anti-HbC. Total anti-HbC is both IgM and IgG. So you can see here, acute infection. Acute infection, both HbsAg will be positive, anti-HbC will be positive. And in chronic infection, HbsAg is still positive, okay? But anti-HbC, only IgG is positive. So very specific for acute infection is your IgM anti-HbC. Take home message, IgM, HbsAg. These are two for recent infection. Okay, this is your take home message. Out of this, most specific is IgM. Okay, it tells you short, this patient has got a blood transfusion or a needle prick or some source of infection in the past 6 months. That's how you need to break this question down into different parts. All right. Okay. So moving to the next question, that is your 11th question. I know this has been a tiring session, but I appreciate your patience being with us. So a 58-year-old female presented with gradually diminishing visual field. Okay, so that's something interesting. She was found to have a pituitary mass. Okay, so the pituitary mass explains diminishing visual field. Why? Because a pituitary mass leads to something known as bitemporal hemianopia. Okay, bitemporal hemianopia. She underwent a transsphenoidal hypophysectomy. Simply put, they removed the pituitary gland through her nose. Okay, so now she has low levels of ACTH, TSH, LH, and FSH. Obviously, so because they've removed the pituitary gland, you don't have any hormones which were previously secreted. So what do? How do you help this patient post-operatively? What hormone supplements are given and what is not required? Question here is, what is not required after removing the pituitary gland? Is it the thyroid hormone? Is it the estradiol? Is it mineralocorticoids or glucocorticoids? Alright, let's see what happens in pituitary tumor. So you have a pituitary adenoma, whether it's functioning, non-functioning. We classify usually them into two parts, a micro and a macro. Alright, when do we operate, or when do we decide that no, we have to remove the pituitary tumor? If either the chiasma, that is your optic chiasma, is compressed, you have visual field defects, you have a pituitary dysfunction or a headache. If all of this is there, then we go ahead for tumor growth. Okay, tumor growth plus or minus visual field defects, we check. Okay, we undergo individualized surveillance. We check for tumor growth and visual field defects, and then we go ahead with a pituitary surgery. Suppose it's very, very small, then we just monitor this. We just monitor the patient. Once he develops a visual field defect, we again go ahead for a pituitary surgery. So you can see here, it goes through the nose, through the sphenoid sinus, and then we remove the pituitary. So once we have removed, you're the surgeon who's removed the pituitary. Now, how do you help the patient? So you help the patient by replacing certain hormones. Do you have to replace the thyroid? Obviously. Why? Because the TSH is lost. There will be no release of thyroxine if you remove the pituitary. So there will be a slow heartbeat, there will be drop in metabolism, and there will be weight gain. So you have to replace your thyroid hormone. You have to give him thyroxine. Next is your growth hormone. Again, growth hormone, it has to be replaced. And follicular stimulating and luteinizing. So that means if these are deficient, what do they call? They call something known as central hypogonadism. All right. So for central hypogonadism, In females, we give them estrogen, and in males, we give them testosterone. Alright. So if she still has an intact uterus, we usually combine this with a progesterone. Alright. Now, last part is your ACTH. That is, your ACTH is deficient. So your adrenal glands are very, very important to maintain your BP, to maintain the intravascular volume, to make sure your electrolytes are normal. So obviously, if the ACTH is lost, your adrenal glands are not going to produce hormones. So what are the hormones that are produced by your adrenal glands? You have your mineralocorticoids, your glucocorticoids, and your sex steroids. So out of this, we have given your estrogen, progesterone, and testosterone. So this need not be given again. So your glucocorticoids have to be given. Why? Because they come under your HPA axis. But your mineralocorticoids do not need replacement because they do not come under the control of pituitary. What are they controlled by? They are controlled by your renin-angiotensin system. Okay. Your RAS system controls your mineralocorticoids. Hence, you do not need to replace them. So the answer for our question is mineralocorticoids. Alright. So the last question for today's session is, this was asked in your previous NEET PG, so please pay attention. A patient presents with fever and chills. On examination, pallor is present and there is hepatosplenomegaly. Alright. On evaluation, dengue malaria is negative, but RK39 antigen is positive. They are asking you what is the treatment of choice. They are not asking you what the patient suffers from. Okay. So that means it's straightforward. If you know what RK39 antigen is for, you will know what is the treatment for that disease. Okay. So the answer here is amphotericin B. Alright. So RK39 is an antigen for visceral leishmaniasis. Okay. So there are few parasitic infections for which you should know the antigens. So there's a tabular column. Okay. So the antigens for visceral leishmaniasis is RK39, a part of our question, and WKK. So these two antigens have been asked. Please remember. Plasmodium, of course, all of you know, HRP2, your PMA, that is your pan-malarial antigen, and your LDH. Then you have a Giardia specific antigen. They might not give you the entire name. They might just give you antigen 65. So you should remember that antigen 65 is for Giardia lamblia. Alright. Galactose-lectin antigen is for Entamoeba histolytica. Or your PI3, that is the pepsin inhibitor. PC, that is phosphorylcholine, is for Ascaris. And your last is 200 kilodaltons, or OG4C3 is for Wuchereria bancrofti. I know this seems to be a very factual question, but they sometimes disguise a factual question as a conceptual question and give you as a clinical scenario. So I want you to remember at least 3 of these: RK39, AG65, your pepsin inhibitor, and your OG4C3. Of course, you will all remember the plasmodium markers because they are routinely practiced in all our colleges. That is HRP2, PMA, and LDH. Alright. So with this, we come to the end of part 1 of internal medicine live 25 question discussion. I will meet you soon for the part 2, where the rest of the 13 questions will be covered. Please stay updated with our YouTube channel. We'll be putting in all the recent schedules, modification of any schedules, and we'll be updating about the future sessions also. Thank you so much for being with us today. Thank you.